Good morning, good afternoon, whatever time it is in the virtual world. My name is Keith Miller. Thank you for joining us. I think Nestle Nutrition Institute has helped put together a fantastic program this morning. Pick your picks. We've got an ambitious task ahead of us. We're going to try to hit on some mitochondrial changes, inflammation, and nutritional interventions in the setting of chronic critical illness, or PICS, or whatever you want to call it. And again, part of our job is to help clarify some of the confusing terminology that goes along with these entities. I think we have the right people for the job, so let's move forward and get started. As far as disclosures go, financial support for this presentation was provided by Nestle Health Science. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented and is for educational purposes only and is not intended as a substitute for medical advice. Reproduction or distribution of these materials is prohibited. All right, let's get started. So here are your speakers. You've got two experts and you're stuck with me for just a little bit. So I'm an associate professor of surgery at the University of Louisville. Then we're going to move on to the good stuff, which we'll start with Dr. Martin Rosenthal. Dr. Rosenthal is an assistant professor of surgery in the Division of Trauma and Acute Care Surgery at the University of Florida, received his medical degree from Mercer College and completed his general surgery and critical care fellowship at University of Florida. He and his group, as many of you will know, have made significant contributions to our current understanding of the topic we're going to be talking about today, which is persistent inflammation, immunosuppression, and catabolic syndrome. And then our closer is Dr. Beth Taylor, who, again, many of you will already know. She is currently a research scientist at Barnes-Jewish Hospital in St. Louis, Missouri. Prior to this role, she spent 18 years in the trenches as a nutrition support specialist in the surgical and trauma ICU. Many of you know her as one of the lead authors on the 2016 ASPEN SCCM guidelines, and she has obviously served in multiple leadership roles, which have made significant contributions in shaping clinical nutritional practice today. So I think we've got the right people, minus me, for the job to endeavor on this discussion regarding PICS. So what are we going to talk about today? We're going to discuss some of the differences, similarities in the diagnosis and intervention for PICS, persistent inflammation, immunosuppression, and catabolic syndrome, and PICS, post-intensive care syndrome, with the S added on to the end for survivors. We're going to talk a little bit about the mitochondrial and inflammatory changes seen in these, and then we're going to round it out with talking about the importance and role of nutrition in these clinical entities. So again, you're stuck with me for a few minutes here. To start, I'll try to introduce sort of a broad overview of the topic and talk a little bit about the evolution of the PICS continuum. I'm a faculty member on the Nestle Nutrition Institute Clinical Nutrition Fellowship for Physicians. So here's what I know it seems like 12 or 13 objective slides here at the beginning. We'll get to the real stuff here shortly. We're going to talk about clarification of some of these terms across the continuum of care. We're going to focus the spotlight on mitochondria a little bit, and then we're going to describe some of the mechanistic cellular response to nutrients in and beyond the ICU. This is my final disclosure slide, or a version of a disclosure slide. I think it's important. There's a rapid acquisition of knowledge, and the evolution of what we understand about PICS is changing on a daily basis. It feels a little bit like the parable of the blind man and the elephant. I think we're seeing pieces of this, whether it's a rope or a fan or a wall. We may be missing the big picture, and in this case, it's the mitochondria. So we're going to talk a little bit about the mitochondria today, and we understand that this is part of a bigger picture. So you're stuck with a trauma surgeon, so we're going to start here with a quote from Dr. Cowley. There is a golden hour between life and death. If you are critically injured, you have less than 60 minutes to survive. You might not die right then. It may be 3 days or 2 weeks later, but something has happened in your body that is irreparable. I think that's a prophetic quote. Here you're looking at the trimodal distribution of injury deaths, where you may be more familiar with a bimodal injury, but this trimodal model does include non-survivable injuries right up front, which includes brain injuries or lacerations to major vascular structures, which result in immediate death. This is the group we try to implement immediate intervention in order to reverse their outcome and save them. And then this is the group we're sort of going to be focusing on today. So it's a group that's been well known for 50 years. Although this was in the 2 to 4 week period, we'll see that we've stretched this out a bit. But this incidence of multi-organ failure and indolent death long after their injuries. So if I had to sum up 4 to 5 decades of critical care in one slide, it would look something like this, particularly in the setting of trauma. Initial high mortality followed by subsequent organ failure and late death. That bimodal distribution, again, the first peak is clipped off just because there's little we can do for that in the hospital setting. This bimodal distribution it was extrapolated in many ways from the Denver multi-system organ failure scoring that was performed, where they saw this subsequent late peak of multi-organ failure after the initial injury. So antibiotics, surgery for hemorrhage control, whether you're talking about source control and antibiotics in the setting of sepsis, and organ support systems have reduced early mortality substantially. Interestingly, they repeated the Denver organ failure study in 2012. The GLUE grant, which is a consortium of trauma centers across the United States, repeated this study and saw that this second peak sort of flattened out. And it's this curve right here, and sort of disappeared. Speculated that maybe this was attributable to some of the co-interventions we perform in the ICU, critical care bundles, early goal-directed therapy, transfusion ratios, MTP protocols, CRRT implementation, and all those things that we think about that have sort of become common practice in the last 1 to 2 decades in our ICUs. So a perception is now this, that we have flattened that curve, that you have an initial high mortality followed by a slowly flattening curve, and the temporal distribution of death is going to look something like this. Now, as clinical nutritionists, all of you know that that perception is not, in fact, reality, as we continue to lose survivors long after hospital discharge, here to 180, 360 days. And that's what we're going to be focusing on a little bit today. I think this study, that's a big retrospective study in trauma from Washington State, looked at trauma case fatality rate. And you can see the yellow line very quickly is going to be your hospital mortality. This is where we think we're making significant progress. We high five as the patient leaves the hospital and say, well, that was a fantastic save. This is the post-discharge mortality. You can see it's going up. And unfortunately, the overall net change in combined mortality has changed very little over this 15-year period of time. And so I think this illustrates stretching out the burden of illness very well. So what do we call this? What do we call this stretching out of critical illness? Well, there's a few terms here. Chronic critical illness is a general term, although it does have a very specific definition, which would be remaining in the ICU greater than 14 days with persistent organ failure. That's sort of the classically accepted definition there. PICS, the S added for survivor, is post-intensive care syndrome. I think of it as a clinical entity. And then you've got this PICS, which is persistent inflammatory immunosuppressive catabolic syndrome, which I think of more as a way to understand the underlying physiology of these other entities. So there's significant overlap. These are all sort of describing the same thing in different ways, and turns into a little bit of alphabet soup, but you can use some of these terms interchangeably. I think what are we talking about here? I think that came into focus a little bit. You look at a secondary analysis of 2 large randomized controlled trials. Again, if you're tired of hearing a trauma surgeon, these are in septic shock. Don't worry too much about the interventions here. More in the secondary analysis, which looked at 6 month and 1 year outcomes after profound septic shock. And you see a third of patients still had significant mobility issues. The black line is 6 months. The gray line is 1 year. You talk about usual care, anxiety or depression, persistent pain and discomfort. So we're starting to begin to define what this clinical entity looks like. This is a cartoon representation of what that brings that more into focus. You're talking about the physical, cognitive, and mental impairments associated with a post-intensive care stay. Dr. Beth Taylor is going to bring this in and discuss it in much more detail and do a better job than what I'm doing now, but I want you to have at least seen it. Here you're looking at long-term prognosis, morbidity, mortality. There is a version of this in the pediatric patient as well. Not only do you consider long-term morbidity and mortality, but you also have to consider the developmental impact, as this critical illness can sometimes strike during a period of important development. And so that's an additional consideration with the PICS pediatric model. And again, Beth will talk a little bit about this. Moving over this other PICS, and we're already confused, but this tries to pull in the immune or the inflammatory model of chronic critical illness and tie it in with the metabolic model associated with chronic critical illness. And I think this is important to helping understand the underlying pathophysiology. So not a separate entity, just a different way to look at it. And I think we're going to look at both of those ways to approach this similar entity and how we intervene on the back end. You all have seen this slide. This is from the Florida group. There's three different ways your patient clinical trajectory can go. They can die very early, they can rapidly recover, or they can enter this sort of smoldering chronic critical illness, which again is our focus today. So, but if you go back to this slide, it all starts right here. Sepsis or trauma or hemorrhagic shock or whatever it is, that is an episode of shock or a momentary pause in the act of death. As again, Dr. Cowley said, this is a bit pessimistic to look at it this way, but not wholly inaccurate even today. A process that once set in motion is irreversible. Which again, we're learning very quickly, but is not far from accurate. But you have to go back and ask yourself what kills critically ill patients outside of the initial insult. We're very good at picking up clinically organ dysfunction. We're very good at identifying macrocirculatory shock. We're very good. We're pretty good at identifying these two entities. This is what we treat and target, whether we're talking about vasopressors or goal-directed therapy, optimization of our systemic pressures, transfusion, ventilation, oxygen delivery. But what we're not very good is at what's happening at the microcirculatory level, these local regional phenomena. So once it reaches a systemic physiologic impact, we're pretty good at identifying it, but not so much here. So we have to go back and look at what's happening at that level. And what happens at that level eventually is organ failure. So we have to ask ourselves, what causes organ failure? Is it cell death? Is it cell dysfunction? Obviously, these other entities like ischemia, reperfusion, toxic lymph, and immune dysregulation are contributors. But is this because we're losing cells in the kidney? Is renal failure a result of that? Or is it because the cells in the renal tissues are not working? I think that's a fundamental question. This is a study that's about 20 years old now. It's an autopsy study that looked at patients who died of sepsis, and they took tissue biopsies from all these different tissues here, brain, lung, heart, spleen, pancreas, all these organs that we monitor for failure in our ICUs. And what they saw was that the tissues were largely unchanged, and that although apoptosis and necrosis were present, in general, it did not appear to be sufficient to cause organ failure. So they threw out this idea that the cellular stress response involves downregulation or potential hibernation of the cells. So maybe it's more dysfunction than death. So if it is dysfunction, well, who's responsible for that? At what level are these cells dysfunctioning? So we're going to pull mitochondria in the spotlight again. I think this is one piece of the puzzle. But you can ask the same question. Are we losing mitochondria, or is it mitochondrial dysfunction? Are there alterations in what the mitochondria are doing, or are we actually physically losing mitochondria within the cells? And I think the answer is that both of those things are true as we start to parse out what's happening. In essence, shock is mitochondrial failure. Shock is ATP depletion. Again, whether you're talking about hemorrhagic shock, and again, the details of these aren't so important, but you'll have copies of these slides, or whether you're talking about septic shock, really ATP depletion at the level of the tissues, and the inability to synthesize ATP in mitochondria is a manifestation of shock, as hooking and unhooking that last phosphate, that ADP to ATP conversion is what keeps the whole world operating, to use others' words. And just a fun fact to take to trivia night, this amounts to 2 AA batteries, or 9 quarters worth of ATP in our entire body that's turning over furiously, and then in the setting of shock may come to an abrupt halt. And that's what we're dealing with here. Not just ATP production, that's not the only purpose the mitochondria serves. It obviously is involved in the regulation of gene expression, heat generation through uncoupling and other processes, calcium homeostasis, steroid synthesis, and free radical or reactive oxygen species signaling. A lot of that's generated from the TCA cycle and oxidative phosphorylation, and we'll see how that moves through in a slide or two. We'll try to sum that up in a slide or two, which I don't know if it's possible. We're going to try. So if that's function, what does dysfunction look like? Well, we already hit on ATP production a little bit, depletion of ATP. And again, I want to focus the discussion, even once oxygen delivery is reestablished and your pulse oximeter says you're sat 98, 99%, right? This becomes a utilization issue, not necessarily a delivery issue. And that's a downstream impact. And that's what we're seeing in chronic critical illness. So they're not in shock for 6 weeks or 6 months, but their ability to utilize oxygen is impaired. Reactive oxygen signaling, these excessive production of free radicals, as we discussed, and you're going to get these danger-associated molecular patterns. And mitochondrial DNA in and of itself is a way to signal to the cell that, uh-oh, we're in trouble. There's a problem here. You shouldn't have mitochondrial DNA floating around a whole lot around here. And that can impact cell death pathways to the degree that if there's too much of this stuff going along, it says, okay, we need to shut this cell down. We need to shut this organelle down. And then you can get disturbances in calcium homeostasis and that sort of thing. So mitochondrial dysfunction is a problem. So what happens in critical illness? You got to follow me here with a few muscle biopsies. I know where they put these things under the microscope and try to measure bioenergetics and what's happening here. You're going to see that a lot of these biopsies are from the vastus lateralis. So I just want you to see where that's at over here. In this study, they looked at that and in the intercostals. And what you saw was decreased mitochondrial content in both muscle groups, decreased ATP and energy-rich phosphates. Energy production varied between the two, so there's not a completely homogeneous response, which makes this really difficult dependent upon muscle group. But I think what you're seeing is reduced ATP, reduced mitochondria. This study took it a step further. Again, you'll have these slides. Don't get too worried about following what's going on here. But this study looked at ATP depletion, antioxidant depletion, as a prognostic predictor. And you can see, although these error bars cross, still they saw a loose correlation with your ultimate progress as dependent on your tissue ATP concentrations. Sort of threw out this idea of bioenergetic failure, which I think is going to be important in the next couple slides. This is a rat study. This is just to demonstrate that these some morphologic changes that you do see at the level of the mitochondria, maybe not at the level of the tissue, but at the level of the mitochondria. Again, I'm a surgeon. I like to see things. That doesn't make sense if I can't see it. And here I can see that these morphologic changes in the mitochondria persist. These were middle-aged and old mice trying to recreate that risk factor of being elderly and developing PICS. And what you can see is the oxidative damage persists in skeletal muscle long after recovery. And I think that's what we're seeing in humans as well. The mitochondria is not idly sitting by. It has some defense mechanisms, and you'll see some of those here. Mitochondria are able to remove damaged mitochondria. We talk a lot about autophagy. You can here, mitophagy is a way to engulf the entire damaged mitochondria and pull it out if you need to. You can make new mitochondria, so-called mitochondrial biogenesis, and I think you can make them from scratch, or you can make them from damaged precursors, as you see here. They're pretty tricky. If you got two partially damaged mitochondria, they can fuse together and peel off one fully functioning mitochondria and sort of dispatch the other. Now, it's a net loss of one mitochondria, but overall, it's a way to salvage function. The final defense mechanism would be to shut down operating systems and altering bioenergetics, which we'll discuss a little bit here. Autophagy, again, I just mentioned it because, again, as an organelle in its entirety, it becomes mitophagy. It's a housekeeping system that you're all familiar with. Goes around and cleans up damaged cellular components or entire organelles, tries to reshuttle that into energy production. The reason I bring it up in this talk about mitochondria is that the mitochondria are a key mediator for the regulation of autophagy. They are a prime source of reactive oxygen species generation, meaning as things move through that TCA cycle, they're spitting off free radicals, and that's a signaling component for autophagy, which is essential to recover from critical illness. Our understanding of this is evolving very rapidly. If you want to pull this article, it's very interesting to read. It talks about what happens in the setting of hypoxia from a gene expression perspective. These folks won the 2019 Nobel Prize for picking up on this. But you'll see this HIF, this O2 sensitive transcription factor, upregulates oxygen-independent ATP production or cytosolic glycolysis, and downregulates oxidative phosphorylation. I got some pictures to help because I know that was a long time ago for me. You're also seeing a little prelude to what's going to happen in maybe macronutrient switching, substrate switching, as fatty acid oxidation is less efficient than carbohydrates, so maybe carbohydrate becomes a preferred fuel source in that early critical illness. So this is to go back to biochemistry again. This will be over shortly, so just hang in there. But protein, carbohydrate are all shuttled down through here. Now, obviously, protein can jump into the citric acid cycle in multiple places. We'll leave fat out of the discussion. And this, in happy times when oxygen's available, this thing spins along and generates ATP and all as well. In bad times, however, in the absence of oxygen, you're not able to shut down oxidative phosphorylation. So you go to these anaerobic pathways. You focus in on glycolysis. Protein even gets that through the Cahill Cori cycle, you perform glycolysis, and so you sort of get focused over here. Dr. Puthachiri, who should be credited for some of these cartoons, as he presented back when we used to all get together in meetings. He presented a slide that looks very much like this, and we've been using variations of it. He did a study where his group did a study, with muscle biopsies of, again, that vastus lateralis on days 1 and 7 in critical illness, and then saw all the same things that we've been seeing already. But they also saw that mitochondrial beta oxidation enzyme concentrations and mitochondrial biogenesis markers were reduced. So now we've lost beta oxidation in the setting of critical illness, and you're sort of stuck in this futile energies or this pathway, this glycolytic pathways, and this is what they sometimes refer to as some of the futile energy cycling. So thanks for sticking with me for that. So let's get to some of the good stuff. What can we do about this if we leave the level of the mitochondria and thinking about the big picture clinical entity? Dr. Taylor is going to talk to us about this. You can't have a clinical entity in the ICU without having an associated bundle, right? We all love bundles. So here's the chronic critical illness bundle, or the PICS bundle: awakening, breathing, coordination, delirium, and early mobility, the ABCs of PICS. Obviously, nutrition therapy is included in several of these bundles as well, and Beth is going to talk to us a little bit about that. If we think about it from a PICS phenomena, where we think about the underlying pathophysiology, Dr. Rosenthal is going to help illuminate some of these issues, and that's where you start thinking about the level of the mitochondria. And this is where avoiding overfeeding becomes important, and potentially adjusting macronutrient provision. How do antioxidants come in and play a role here? Right? Stimulating mitochondrial biogenesis is difficult. I don't know that we've been able to do that at this point, but that is a future area. And then as you talk about influencing cell death pathways, again, you're talking about avoiding overfeeding. Obviously, the generation of these reactive oxygen species via oxidative phosphorylation, it's probably protective for the mitochondria to avoid going down those pathways. So we want to, and stimulating autophagy becomes important. Other things, I think judicious antibiotic use. Again, there once was a theory, or there is a theory, that mitochondria were bacteria that were engulfed by cells and repurposed for energy production. So antibiotics may have an inhibitory effect on mitochondria in and of themselves. There are toxic agents we use in the ICU, propofol being one that binds and inhibits. You got some uncouplers like your inhaled anesthetics and things along those lines, and glycemic control. So this is as you think about from a mitochondrial perspective. Again, a lot of these things are experimental, so don't take this to the bedside just yet. But I think it has changed our understanding. We've already seen this in clinical practice as we've moved from full nutrition support and early critical illness is what I'm talking about here, and transition to trophic feeding. Where we'll be at in coming years, I don't know. You'll get a chance to see this graphical representation of an approach in the ICU from Dr. Taylor here shortly. So don't worry so much about the details, but you can see the slow ramp up over time to avoid overfeeding. The final slide, on reactive oxygen species signaling. Again, I just want to show you here, oxidative phosphorylation really churns these things out, right? And so it may be a protective in order to avoid this pathway in the setting of critical illness. So the other piece of the puzzle is not only potentially trying to avoid these through macronutrient selection and avoiding overfeeding, but also antioxidant provision in our ICU. This is just the electron transport chain on the mitochondrial inner membrane, and you can see all these antioxidants that sort of help capture these free radicals or these reactive oxygen species. And so utilization of these things in the ICU, and I know we're all familiar with the redox, the Signet, and the MetaPlus trial. So we've not figured out exactly how to use these, but it may be part of the equation. So that was a long, winding road, and fortunately, you're going to move on to more coherent stuff here shortly. But in conclusion, I know the terminology can be confusing, but it really all just talks about the same entity, just comes at it in a different way. Mitochondrial dysfunction contributes here, but we don't know yet what to do with that. And obviously, there's still a lot to learn and discover regarding the pathophysiology and potential novel therapies in chronic critical illness, PICS, or whatever you want to call it. So I thank you very much. That painful 20 minutes is over, and we'll get on to the good stuff. So the next presenter going to be talking about persistent inflammation, immunosuppression, catabolic syndrome, is Dr. Rosenthal. So thank you very much, Dr. Rosenthal, and you can take over.
All right. Well, thank you, Keith and Nestle, for having me today and that kind introduction. My name is Martin Rosenthal. I'm here to present one of the PICS paradigms, which is the persistent inflammation, immunosuppression, and catabolic syndrome. Here are my disclosures. And here are our objectives. We're going to try and identify from an observational retrospective data bank which patients do better as far as rapid recovery versus the PICS in our surgical and trauma ICU patient population. Describe biomarkers for the persistent inflammation, immunosuppression, catabolic syndrome. Discuss a theory of PICS pathophysiology, as well as discuss nutritional adjuncts applied to this patient population. Here you can see an early concept of multi-organ failure. And what we see here is that the SIRS phenomena happen first from a systemic inflammatory response. And then we used to think that there was a compensatory mechanism that would drive us back to homeostasis. But this early concept from bone has been disproved at this point. And what we have now is that we have a better understanding that all of this happens simultaneously. Here you see that in the yellow box, there's sepsis, but this can be any really big inflammatory insult. It could be polytrauma, it could be pancreatitis. And what you end up finding out is that the innate immunity and the adaptive immunity all are in disarray until we either recover or we hit that 14-day mark where we have designated this to be chronic critical illness. And subset of those patients go on to develop persistent inflammation, immunosuppression, catabolic syndrome. And that's generally because of the inflammatory response. They remain immunosuppressed. And the inflammation is driving catabolism. And what we'll discuss later is how is this catabolism really borne out, and do our patients really get benefit from the nutritional therapies and the nutritional adjuncts that we have. Here you can see that the phenotype of chronic critical illness and PICS has a prolonged ICU stay. These are, for better or worse, the rocks that remain in our ICUs. They have very long hospital stays. They have recurrent inflammatory insults and nosocomial infections. They have high acute phase responses, and I dare say that they also have low negative acute phase responses. These are the patients that have low prealbumins and albumins. We used to think that those were markers of nutritional therapy, but we now know better than that. They have higher CRPs. They have neutrophilia and lymphopenia. They have low PMNs or neutrophils, and they have low lymphocyte counts. And we know that the lower the lymphocyte counts, the worse off patients do. And one of the things that I'm focusing on more with my research is that they have cachexia despite our adequate nutritional therapies. They have a wasting syndrome. They have poor wound healing and decubitus ulcers. And then they get transferred to a long-term acute care facility only to die an indolent death, because we now know that after about a year of these patients that come to the PICS phenomena don't do well at that year mark. And then they have sepsis recidivism, despite the fact that we send them to skilled nursing home, wound care facilities, LTACs, all these things, they come back to us because they have recurrent sepsis. And we have found out that recently, we used to think that it was maybe an infection that was never fairly treated, but we now know that these infections are actually different. So we recently published this in JPEN in 2020. And what I looked at was a retrospective post hoc subgroup analysis of sepsis patients in both our, in our trauma ICU patient population, as well as our surgical ICU patient population. All these patients received enteral nutrition. We strongly encourage in the first 10 days that these patients receive immunonutrition that has arginine, omega-3 fatty acids, nucleotides. Then after that, we change more to a standard formula with protein additives. And the groups that we defined were the chronic critical ill. And we have defined that as an ICU stay longer than 14 days, which comes from a study that Azra Biorak, who is critical care trained, but as a nephrologist, she looked at AKI. And what she found is that if you have one instance of AKI before that 14-day mark, your mortality actually increases for the hospital stay. And so we were looking at organ dysfunction at that point. And she clearly defined that if you have organ dysfunction within those 14 days, your predictive morbidity mortality goes up almost like a skyrocket. And so we were looking for her to kind of help define this multi-system organ failure. And as we know, if the kidneys go, we have a world of problems. And then we also said, well, if we're going to use ASRA study, we're going to look at all organ dysfunction, and we look at SOFA score to predict our organ dysfunction. And if they have a ICU length of stay greater than 14 days with high SOFA score, we have found that these patients are defined as our group of chronic critical illness. And we compared them to the rapid recovery, those that were in the ICU, but were, for whatever mechanism, able to restore homeostasis prior to the day 14 and get out of the ICU. They are rapid recoverers. They get out and recover, and they move on with life. And from this group, I found 56 chronically ill patients. I matched them to 112 rapid recovery, and I doubled the number just to increase the power for this analysis. And we matched them for the Charlson Comorbidity Index, age, sex, and SOFA score. And what we found was that chronic critically ill received 75% of their goal calories for the first month. And that was my time mark. I wanted to look at the first month. How well did we feed all these patients? And if we feed them well in the first month, they should be adequately fed, and they should be able to become anabolic with some of these nutritional supplements, especially if we give them high dose protein. We use an evidence-based gold standard protocol that has been vetted many times over. And what we ended up looking at was that if I excluded the first week of their hospital stay from this nutritional protocol, we actually reached 88% of their nutritional goal calories. And that's because if you think about my patient population as a trauma surgeon or a surgical patient where they are met with our acute care surgeons, myself and my partners all staff that service. These are the patients that are going back and forth for damage control operations. They're going back and forth for sepsis source control. And so some of the GI tract might be in discontinuity. They might be on pressor therapies for septic shock. And so in our protocol, we find that those are the patients that we're not going to be feeding all that great in the first week. But when you get over that hump, you've restored continuity. They're weaning down on their pressors. They're no longer on pressors. We start feeding those patients. And so the next 3 weeks, we actually reach a pretty good standard of nutritional therapy. Because when you look at the literature of all academic institutions, we usually are right around that 60% mark for reaching goal calories. And when you see the results, most of the CCI PICS patients have a non-home discharge. 81% were discharged to a skilled nursing home. They were discharged to an LTAC or hospice. And some of them even died in the hospital, whereas only about 30% of the rapid recovery were discharged to those designations. Most of the rapid recovery go to rehab because they have a good high rehab potential, or they're going home. And then the 12-month survival, almost a third of the patients died if they had CCI PICS. There was only 8% from the rapid recovery cohort. And then when we look at the biomarkers for what we defined as persistent inflammation, immunosuppression, catabolic syndrome, all 56 patients that were CCI were actually found to have this very robust PICS response. And I want to show you some graphic pictures to show that these are our PICS patient population. So they have higher inflammation. And what you can see is that the CCI cohort is in that red line. And the rapid recovery is in that light blue line. And they have statistically significant higher IL-6, IL-8. These are inflammatory biomarkers. They trend very well with CRP. If you don't have these biomarkers readily available for you at your institution, look at CRP. It really kind of is a collaborative biomarker in the sense that if your CRP is off the charts, you can almost predict that your IL-6 and IL-8 are going to be very high as well. There's more immunosuppression, and we looked at the absolute lymphocyte count, which again, when I showed you the phenotype, these are the patients that have lymphopenia. And the CCI cohort certainly had lymphopenia. It wasn't really statistically significant until we reached that 12-month mark, but you could see that the trend there certainly depicts lymphopenia. And then we looked at soluble programmed death ligand 1, which is SPDL1. And that is a very interesting biomarker of immunosuppression. And it was statistically significant virtually throughout the first year of CCI PICS. Additionally, we looked at stress metabolism, catabolism, and we also looked at, stress metabolism and catabolism. And glucagon-like peptide is actually a really good biomarker for stress metabolism because the more GLP-1 you have around, the more insulin resistant you're going to be. You're going to have higher hyperglycemia events, and it's just a marker of stress metabolism, statistically significant there. And then the urinary 3-methylhistidine level, you could see there's no asterisks around, and that's because it wasn't statistically significant, but you could see that there's a trend that these patients have muscle breakdown. And what urinary 3-methylhistidine is, or the 3-methylhistidine in and by itself, is when you start breaking down lean muscle mass, you release this into your serum and it's cleared by your kidneys. And so what ends up happening is it's excreted in your kidneys. And so it's a good biomarker for catabolism. But as you know, our patient population, especially in the trauma patients who have ATN from shock, our septic patients who really have AKIs, what we ended up doing was we went back and looked at urinary 3-methylhistidine and corrected for a creatinine ratio, because if you have an AKI or you go into acute renal failure, you're not going to be excreting this at the same rate. And when we did that, it still had a very similar trend, but again, at the 6 and 12-month mark, it was statistically significant. So next, I want to talk about something that's called the Zubrod Performance Scale. This is kind of a functional outcome scale. And what we could see that 0 is fully functional. You're back to baseline. You're doing great. You're thriving. 5 is dead, but most of the patients that we report are the ones that are 0 to 4, and 4 being completely disabled. They're virtually bedbound. They're reliant on everybody else to help take care of them. And what we find with the CCI and PICS patients is that their average is about 3.5, slightly lower than 3.5, and they get to about 3.25 at the year mark, whereas the rapid recovery are virtually back to baseline. This is daunting. If I'm a CCI PICS patient, I'm thinking to myself, wow, how am I not getting back to baseline at a year out from my initial insult? And that's because of a whole different problem. And we're trying to figure out, is it genomics? Is it nutritional support? Is it the medications we give patients? Is it the vast insult that these patients had to endure? Is it everything that we do for these patients in the ICU? And the answer is yes to all of the above. It's probably multifactorial, and we need to be able to come up with better therapies for this patient population. And then we had the SPPB, which is the short physical battery. And you can see that these patients functionally are still lower than the rapid recovery patients. Next, we looked at quality outcomes, like how do you feel? And we looked at the EQ-5D, which is a questionnaire that these patients can take, and it essentially asks them, how's life right now? How are you doing? Do you feel good? Do you feel like you're fully restored back to baseline? And you can see that the CCI patients had a higher higher answer, which you want a golf score on this one. You want a low answer for all of these. Again, this just shows that the quality outcomes favor the rapid recovery. And so at the end of this, even despite our evidence-based protocol for nutritional therapies, gold standard, following guidelines, having dietitians, having a multidisciplinary team looking at this, these patients still had PICS and their functionality, quality outcomes were not that great. So what's the pathophysiology of inflammation driving this catabolism? One of the major differences between PICS-S, my PICS, the persistent inflammation, immunosuppression, catabolic syndrome, and then the PICS-S, which is the post-intensive care syndrome, is that Doctors Moore and Moldauer, two of my great mentors who were looking at this from an epidemiologic standpoint with a big, large NIH grant called a P50 grant, they ended up offering that we have an epidemiologic standpoint why this actually happens. We have an immunologic insult, and we have a malnourished mechanism for the new multisystem organ failure or multisystem organ dysfunction based off the SORFA score. And this phenotype, along with the characteristic biomarkers that were shown previously, they just don't do well. Not all patients that have PICS-S, the post-intensive care syndrome survivors, actually develop the PICS, let alone CCI. So PICS-S largely is predicated on the fact that you were actually admitted to an ICU and you have sustained some sort of dysfunction post-ICU care, whether it's neurologic, neuroendocrine, whatever have you, they fall into the PICS-S. But in our PICS, you actually have to develop this chronic state of critical illness and then develops into this persistent inflammatory immunosuppressed catabolic syndrome. So though the stigmata for being an ICU patient rings true in both patient populations, cognitive dysfunction, muscle weakness, we call that, the ICU acquired muscle weakness, chronic pain syndrome, neuroendocrine disorders, etc. We share those, but at the same time, not every single patient that develops the PICS-S will actually go on to develop CCI or PICS. You just have to be admitted to any ICU. Again, when I said that we have an epidemiologic or an immunologic standpoint for this, Dr. Efron and colleagues has shown that these myeloid-derived suppressor cells can actually be associated with chronic immune suppression after severe sepsis, septic shock. And what they end up showing is that these are immature cells secreted by the bone marrow in response to inflammation. They come straight out of your bone marrow and they circulate all throughout your blood system. They may go to some lymphoid tissue, and where they end up, they secrete high concentrations of arginase 1, which breaks down arginine, causes T lymphocyte dysfunction and suppression associated with arginine deficiency. And they're pro-inflammatory. They keep spitting out that inflammatory cascade that, really revs up the catabolism because you're still inflamed at that point, which drives this cachexia-like state in critical illness. And these myeloid-derived suppressor cells are very hard to turn off. It's not like I could give some sort of therapy or immunotherapy, medicine or something to push them into maturing into a good myeloid cell, like a lymphocyte or a PMN or a macrophage or something like that. They still stay highly concentrated in the bloodstream. And so here we could see where the arginine deficiency actually truly comes from. And some of it is the arginase induction. Some of it is because we have decreased endogenous arginine synthesis. And a lot of it actually comes from the fact that these patients remain NPO while they're in sepsis, septic shock. And what ends up happening is you have this physiologic stress that you could see on the right-hand corner, and then on the left hand, you have arginine. So it comes in, then you have these MDSCs secreting the arginase 1, and you have this inordinate amount of physiologic stress. And again, it's sepsis, septic shock, it's trauma, polytrauma, it's big burns, pancreatitis. What we treat in our ICUs And ultimately, what you end up is you have an amino acid that becomes deficient. And what ends up happening is you have an increased risk of infection, increased risk of inadequate oxygenation at microperfusion because you don't have arginine to shut down the nitric oxide pathway at the level of the tissue. I want to say that again, at the level of the tissue. I do not think it's a systemic response. And what we find is that the T cell receptor of the T lymphocytes is that the zeta chain actually needs a pure concentration of arginine to be fully functional. So if you're arginine deplete, your T cells don't respond to antigen the way that they ought to. And what that ends up meaning is that you have energy to recall, and you don't really have the response from an immunologic standpoint that you should. So now what? How do we get ourselves out of this pickle? Are there any nutrients we can potentially use to decrease the inflammation that drives the catabolic state? And how about the immunosuppression? This is something that I derive a lot from the literature, and it comes a lot from the University of Florida. And here we see arginine again. It's the conditional essential amino acids. We've already kind of covered some of this. You have that T cell function. You have innate and adaptive immune response that is absolutely required for. You have actually decreased wound healing. Barboul et al. Back in the 1990s, 1980s, even as early as the 1980s, he showed that if we don't have arginine floating around in our serum, our wound healing is compromised. And then you have anabolism. Anabolism is really an interesting concept because when we are fighting for our lives in any of these inflammatory states, the mTOR pathway is downregulated. Once you have source control, the patient is on the rebound, potentially even that rapid recovery cohort, you can give them this branched chain amino acid and they become anabolic because it stimulates the mTOR pathway. But you need arginine in that pathway in order to actually activate it and be synergistic. Now, when you talk to the CCI PICS patient population, I do think leucine and arginine combination still does have a good response. It just isn't as robust as those that are getting out of the ICU. And what I postulate is that what you can see on the bottom of the screen, the B format where individual cell response, you see that the MDSCs have this green trajectory. They go up, and then they plateau. And so what I think is that if we can hit them with arginine, potentially even leucine, then we can turn this around and the arginine may drive the MDSCs to maturation so that they're not spitting out the inflammatory cascade and we can get back to homeostasis better. I just covered this. This is the leucine stimulated pathway for anabolism, or at even best anti-catabolism. And we know leucine, when it stimulates the mammalian target of rapamycin, you have increased protein synthesis for hypertrophic muscle growth, which means we get our lean muscle mass back potentially. And it inhibits the proteasomal or the autophagy protein breakdown, which equates to anabolic nutrition. Here's how we see that. We see the mTOR1 is for largely cell growth, relies on downstream effects. Dr. Martindale shows this in some of his slide decks. Ultimately, the mTOR2 promotes cell proliferation and survival. So what we're trying to do is hit that mTOR1. And again, leucine and arginine are required for mTOR1 activation. And if you have insufficiency in both, you're not going to get that anabolic nutritional effect. Now, what about omega-3 fatty acids, EPA, DHA from fish oil? It minimizes inflammatory response by decreasing production of inflammatory cytokines, increases immune response by enhancing lymphocyte function. And these are all mediated by cell signaling, getting into the lipid raft. And we have a high prevalence of omega-3 fatty acid deficiency in US. And out of the 655, we see 89 were omega-3 polyunsaturated fatty acid deficiency. So what does this mean? I think it means that we should all be taking fish oil. I myself do it. I don't tell my patients go home and take fish oils if I'm not doing it myself. I live by my own rules. I do take probiotics and I take fish oils each day. And I think this is one that may help me if I ever become sick. And since about 2012, we've looked at all the literature, we've added to it, and you can see that we've added almost double the studies and double the patient population. And I recently worked with a very, very smart group of physicians, and we published what the new omega-3 fatty acid literature supports as far as parenteral lipid. And what we see is that there's a decrease in infections for hospitalized ICU patients, 40% lower. There's decrease in sepsis, 56% lower. There's a decrease in length of stay. And though the mortality wasn't statistically significant, you could see that there was still a 16% reduction, which is not zero. So I do think if we had a higher cohort, I think we would see that this might grow to potentially being statistically significant. And what about a novel kind of omega-3 lipid byproduct? This is gaining tremendous amount of interest and popularity. These specialized pro-resolving mediators found by Dr. Charles Serhan essentially have shown us that they can help promote resolution of the inflammatory response. There's 3 different species of pro-resolving mediators. There's resolvins, there's merisins, and there's protectins. And each of these are found in pico-nanomolar all throughout our system. They have very low bioactivity, which means you don't need a whole heck of a lot of these SPMs sticking around in your serum to have an effect. And so what they end up doing is they have a resolution of inflammation is now held to be an active process. We used to think that the surge response or inflammation just petered out. Maybe it got diluted out in serum. Maybe something happened that we got source control and it shuts off the inflammatory response. But we now know it's an active process. You need these SPMs sticking around. Nature, the human body, everything that we hold near and dear to our hearts that is not built and created has a yin and yang. For every action, there's a reaction. And so if there is an inflammatory response, there needs to be an anti-inflammatory response, which means bone, when we got back to the very beginning of the SIRS-CARS phenomena, bone might have actually been onto something in the sense that we do have a SIRS response, and now we need the anti-SIRS response, which is going to likely be the omega-3 fatty acids or these SPMs. I'm just speculating because we have an active process to this resolution cascade. We report that the endogenous omega-3 DPA is converted during inflammation resolution to novel 3 byproduct specialized pro-resolving mediators. And so ultimately, I do think that these SPMs are going to help us break that inflammatory cycle, and we may be able to resolve some of the inflammatory insult. Next, I wanted to share some of the data that came from a post-hoc analysis from the Glue Grant study. Gene expression pro-resolving lipid mediators pathways associated with clinical outcomes in trauma patients. So this post-hoc analysis looked at resolvin scores and leukotriene scores and tied them to clinical outcomes. They looked at 96 patients, and they had complicated ICU stays or hospital stays versus uncomplicated recoveries after blunt trauma. Complicated in our context might be the CCI PICS patients, whereas the uncomplicated may be the rapid recovery folks. When they looked at all the genes were combined into scores, and these genes looked at what makes SPMs, the gene receptors, what breaks down the SPMs, what blocks gene receptors. Those are the numerator denominator, and what you end up having is a score. Everything that helps promote SPMs is on top. Everything that hurts SPMs was on the bottom. And what we found was patients with uncomplicated recoveries had differential and higher resolvin score and a lower leukotriene score. So what does that mean? They had a higher pathway or a higher mechanism for resolving their inflammation, and they had a lower mechanism for the inflammatory cascade based off of our leukotrienes, which are the pro-inflammatory mediators from our lipid byproducts. Here's what the graphic analysis showed us. So you can see on the left, the resolvin score for the uncomplicated recovery was higher. And then on the right, as they said, the leukotriene score was lower. It did cross over later out, but that's what they ended up finding out. So what I did is I did a pilot study, and I looked at our own institutional database, and we did the genomic cascade for all of these leukotriene and resolvin scores. And what I found was that our pilot study, really reflected what they found for the leukotriene score. So the chronic critical ill PICS patients, very much probably tied to their complicated patients, had a higher, more robust inflammatory response. That makes sense to me. I get that. But then what we ended up finding out was that if you look at the genomic array for the resolvin score, our CCI patients had a much higher resolvin score. And I do think that if we take this into context of what genomic science is about, that usually means that there's a feedback loop somewhere in this mechanism. Whether you don't have enough substrate, which is the omega-3 fatty acids, you don't have the catalyst to produce the omega-3 fatty acids, or your receptors are impermeable to actually binding the SPMs, largely would show that we have a higher response for the resolvin score. That means their genes are all turned on, they're revved up, they're ready to produce resolvins. They just can't. So the feedback mechanism is probably broken, which, is a hypothesis driving study nonetheless. So here's a hot topic that we're going to talk about real quick. It's microbiome and how the gut bacteria can impact health, not only health, but potentially even dysfunction. Lots of studies coming out. What are the mechanisms and the interaction of health microbiome that protects the host? We just don't really have a great idea because we don't know which bacteria it is. We don't know how it does. Is it a gut-lung interface? Is it a gut-brain interface? There's all these studies that are coming out right now. And what we found was that Ilya Mechnikov in 1907, who was an immunologist, he actually discovered the macrophage. He was a Nobel laureate. And what he postulated was that a group of Bulgarian peasants were living longer lives based on a epidemiologic study. They did so because of their consumption of sour milk, i.e. they were drinking bacteria. And what he looked at was he already had his Nobel Prize, and he went around and studied different populations, and he saw what they were eating, and they saw how they were thriving, how they weren't thriving, and who had risk factors. And he came out that this Bulgarian population were living longer because they had a fortified GI tract. And so how do we take that fortified GI tract and just dash it against the walls? I dare say that myself and my colleagues, anybody who practices medicine in the ICU, alters the microbiome. And we see that time and time again in the literature. Blood products, crystalloid resuscitation. If you have somebody who's in sepsis, septic shock, burn, they're trying to get out of that hypotensive state, and you're pounding away with crystalloid. Opioids even can alter the microbiome. It turns on virulent factors in Pseudomonas that we've seen. Broad spectrum antibiotics kill off a lot of good diversity in our GI tract, and may pave the way for nosocomial infections like C. diff, enteritis. Even our acid reducing medications can alter the microbiome. Certainly vasoactive pressors decrease interluminal nutrients predicted by delays in feeding, parenteral feeding, and then bowel preps if you're a colorectal surgeon and you have to prep your patient before you do an anastomosis, and certainly surgery. And the person who really shed a lot of light on this, Dr. Alverdi, has a great series of publications out that shows us how we take this normal quiescent microbiome that helps us and supports us in health, and it peters out as we add insult upon insult that we see on the left hand of this paper, and it transitions that microbiome all the way to a pathobiome where these normally, quiescent bacteria turn on virulent factors, and they say, basically, if you're not going to feed me and you're going to stress me, I'm going to start getting my nutrients from somebody else, and that nutrient load is coming from you as the patient. And so what are the mechanisms of probiotics that could potentially help us? We see competitive inhibition, barial increase or physical barial increase, which is the mucus production that helps us in H. pylori, for example. Decreased adherence, attachment of virulent microbes. They actually produce some proteins in some ways that they can actually defend us. They preserve tight junctions. That's a huge one for us. And they actually stimulate good host immune function. They are the ones that actually take in antigens from the GI tract and spit out IgA, or they share it with their B lymphocytes and they tell us, well, we should probably make antibodies to this. So what I wanted to kind of come to a close with was, I looked in the literature, and recently Anton, the last author of this publication at University of Florida, came out with evidence-based nutritional and pharmacologic interventions targeted at any kind of inflammation. He looked at low-grade chronic inflammation in middle-aged and adults. And this was a systemic review and meta-analysis. And he looked at 49 articles, and then he looked at each compound that he studied, which decreased inflammation. And he was looking at articles that published on IL-6, again, it trends with CRP, but he looked at on IL-6 and CRP. And what we found was, lo and behold, probiotics actually decreased the amount of inflammation from a biomarker standpoint greater than virtually everything else, which blew my mind because I thought it was going to be omega-3 fatty acids. And here you can see that there's literature that supports we need to fortify our GI tract. We need a probiotic protocol. We need to be able to find and target different areas of our GI tract and be able to give it a high biodiversity of bacteria to help us so that we can get back to our normal homeostasis and be able to resolve our inflammatory insult, our immunosuppressive insult, our catabolic syndrome. So here are your clinical takeaways. Evidence-based gold standard nutrition protocols may not be sufficient. We saw that literature. Biomarker evidence of PICS is irrefutable. And now we need to focus on additional ways of treating it. We need to stimulate our colleagues in the nutritional world to say if our nutrition that we're giving them based off the ASPEN SCCM guidelines might not be able to save our CCI PICS patients from a clinical standpoint, I would say that we now need to look at adjuncts. We need to push past, grams per protein. We need to get to some sort of normalcy where we can study this and be able to promote health in this vulnerable patient population. The old ebb and flow physiology has been replaced by a simultaneous inflammatory immunosuppressive state that drives catabolism and introduces PICS, and specific amino acids, omega-3 fatty acids, probiotics hold some promise for these patient population. With that, I really, truly appreciate you guys listening to me. This has been a great endeavor for me. And now I want to introduce another one of my colleagues, Beth Taylor, who is a powerhouse in this field. She is going to introduce the post-intensive care syndrome survivals. And I'm going to turn it over to her at this point.
Thanks, Martin. And I want to thank Nestle for inviting me here today to be part of this symposium. I'm going to talk about the nutritional needs of post-intensive care syndrome survivors. These are my disclosures. These are my objectives. And I want to just bring your attention to the purple box just for a little clarification for the presentation so it's easier for you to distinguish one PICS from the other PICS. We are adding the -S on the end, but just so there's no confusion, if you go to the literature to look stuff up, it's all going to look the same. So I just want you to keep that in mind. So what is PICS and who gets it, right? So Dr. Miller helped us out there a little bit and went over the different types of PICS. We know it is after an ICU stay, and there's about 5 million ICU admissions every year, and most of our patients do great. But over 50% of them are going to have some issues in one of the 3 domains that Dr. Miller mentioned: mental impairment, cognitive impairment, or physical impairment. And what happened this year, right? We had all these COVID ICU admissions. So it just means that we're going to be flooding with even more ICU patients that are going to need us here in the near future. And then this kind of just lays it out again what PICS is, but this diagram actually came from the group of stakeholders that came together, and you can see different disciplines in 2010 at the invitation of the Society of Critical Care Medicine. So this is when this PICS was born. And the thing is about most of these patients is they don't suffer from a single component or just one domain. There's a lot of overlap. In this study, what this group did is they looked at their patients at 3 months post-discharge and 6 months post-discharge and how many were in each domain and where the overlap did occur. Now, if you look at it, they say it as PICS-free patients, but you can just do the math, right? So if 36% of the patients were PICS-free, then if we kind of do your math and you go back, okay, so 4% of the patients then actually had PICS. So they found that even at 12 months, even that more patients were PICS-free, there was still a lot of patients that had PICS. In fact, they said 6 out of every 10 of their patients discharged from the ICU developed PICS. But what about these COVID patients? I told you that we have a lot of patients in the ICU because we were taking care of all these COVID patients. Will they also suffer from PICS? So let's look at some small studies that have come out. This one from Austria, 23 patients in rehab after having COVID. You can see kind of the symptoms that they're suffering from. So they have a lot of those same symptoms. Same with this small study in the UK. Right now, all we have are small studies because it's still a new phenomenon in COVID patients. We're starting to just get to them. Excuse me. And in this last study in the UK of 32 ICU patients and ward patients, they wanted to see, do ward COVID patients also have symptoms? Well, some of them do, but not as much as the ICU patients. But look at what is at the top. In these COVID patients, it's fatigue, the breathlessness, the PTSD. So it's just a little bit different, but they still have PICS. So how are you going to recognize if your patient has PICS? What might you see or hear when you're on the floor taking care of your patients or in the ICU? And I bring this up because it's important that all disciplines know what is happening with their patients and to be able to recognize these symptoms. Now, a patient may not say, I can't write a check like I have on this example here. You think, Beth, why would I ask a patient that? But they may say, I can't fill out my menu, or I'm not sure what that food item is. So if you start to notice any of those kind of changes in your patients, you should share that information with your team members. The next question is, how long can it last? Does this go on for a long time, a few days? Well, in this study, you can see that by 12 months, most patients who suffer from PICS are not back to work, are not back to their normal, over 50% or right at 50%. That doesn't, even if they do go back to work, even out to 72 months, some of them still have cognitive difficulties. That follow up with another study, and this is in COVID patients, and they looked at these COVID patients at baseline of discharge, 1 month after discharge, and 3 months after discharge. And because, as I know this is hard to read, I kind of blew up the percentages for you. So at the top, you see upon, and I'm sorry, I misspoke when I said baseline was right at discharge. That was actually when the patient was admitted to the hospital. What did they report? So at baseline, 26% maybe needed an assist device or something like that to mobilize. But at 1 month post-discharge, 75% of these patients needed help with mobility. 3 months out, still 57%. And then you can see the percentages for the usual activities, and that could include doing their shopping or their cooking, food preparation, and anxiety and depression is at the bottom. So at 3 months, these patients are still depressed and still have issues with anxiety. We have to think about how that may affect their nutritional status. So we now know, PICS is not a good thing to have, but it's going to happen. And there's a lot of risk factors that maybe we can address while they're in the hospital. So you see here on the left-hand side, some of the risk factors that go into these different domains. And so these are the ones we want to try and, limit as much as possible. And one of those, if you look at the very bottom, immobility and lack of nutrition. So how are we going to do that? How are we going to make sure that we do the best we can for our patients? Well, we know there are bundles out there that help minimize sedation and try to decrease delirium in the patients. But what are we doing to make sure we provide adequate nutrition throughout these patients' stay and promote their motility? You know that when you talk to your case coordinator on the floor and they say, the minute that patient hits the floor, I'm planning their discharge. Well, maybe we need to do that too as dietitians, because from the moment they hit the floor, from the moment we see how long they're in the ICU, we know whether or not they have a risk for developing PICS. So when we're doing our education or our nutritional interventions, we shouldn't be tunnel vision. We shouldn't say, I'm just going to worry about my tube feeding while they're in the ICU. No, we need to pass on to our colleague on the floor, who needs to pass on to their colleague in rehab. Like, this is where we are. This is where we're still behind the eight ball. We need to start education with the family and communicate with them. What is your loved one going to need when they get home? Because we can only do so much while they're here. And what might you expect? We may say, you need to maybe seek some help. If they're still not eating well, seek a dietitian outpatient visit. Because where do these patients go? Where do they go for their PICS care? There's some PICS clinics around the country, but they're not popping up all over the place. So most people still go to their general practitioner. After a while, like 3 months later, if you look at the 1 month, 3 month on here, they might go to a specialist outpatient clinic. A lot of them just get it from their physical therapist if they're weak. They'll ask them questions. Not too many are going to a dietitian. I didn't circle it, but look right next to that. A lot of people just ask their pharmacist what's going on. So can we make a difference in some of these settings? So at my own institution, I'm part of this study where we're doing a feasibility trial of a post-intensive care clinic for patients that had an ICU stay with COVID. And you can see it's a multidisciplinary group. And it's really just to make sure we can do it. Can we get the platform to work? Can we get the patients to log in? Because it's 100% virtual. We don't ever see them in person. Can we get the assessments that we need virtually with the patient, talking to them and their family? And then when we pass all, we like triage what we think they need. We make recommendations. Does their primary care physician listen to us? So we saw this as a way to maybe help that primary care physician. And while the primary outcomes are just the feasibility, we're also looking at a lot of secondary outcomes, including the must for screening for malnutrition risk. As many of you know, we have patients that enter our hospital that are not malnourished, but then if we were to rescreen them, they probably become malnourished. Well, these patients, we're going to see a lot of them are out there, start malnourished. Do they get better that way? I also have the opportunity, because we're all on this call for 60 minutes virtually, to ask them anything I want or address any nutrition issue they want to bring up. So it'll be interesting to see our results. So let's just take one last moment and think about the role of nutrition in PICS throughout the continuum, from our ICU to our floor patient. I think we can agree these are the main things that happen to our patients when they're in the ICU. The immobilization, there's a lot of barriers maybe to getting them fed adequately. The stress, inflammation, and Dr. Miller talked about some of that and what Dr. Rosenthal went over. And the fact that they're isolated and sedated. And this was all even worse, right, during COVID. So what do these things lead to? So think about immobilization, leads to this deconditioning and this weakness. And so as a dietitian, we need to think about they're losing muscle mass, right? So what are we going to do, 3 months down the road to help these patients regain this muscle mass? What do we need to teach them? Think about our barriers to nutrition. In the ICU, we do a pretty good job of keeping their enteral nutrition and parental nutrition going in their hydration. But what happens when they go to the floor, when they get extubated and they pull the feeding tube and they just don't feel like eating? Do they become malnourished? Do they become dehydrated? And remember that inflammation and stress, it not only will it lead to issues with potential ischemia that will then maybe lead us to delay nutrition, But both of those things, delayed nutrition and that increased stress response, it burdens the integrity of our GI tract, as was mentioned earlier, right? So that microbiome totally changes. And I wish we were all giving probiotics, as Dr. Rosenthal mentioned, but probably that's not part of our normal routine throughout their ICU stay and ward stay, and telling them to do it when they get home. And then also they can develop delirium. What's that mean for us in nutrition? So if we go one more step, this weakness is going to be this inability maybe to feed themselves or to go shopping. We know malnutrition can lead to increased infectious risk or readmissions. We know that if they're dehydrated, they may have syncope. You know, my mother called me the other day, Beth, I'm so dizzy. So I'm like, okay, you got up dizzy. I go over there, try to figure out what's wrong. Figured out she had drank hardly any water. So I guess I need to start at home with educating my mother on how to drink. You know, she's 81 years old because she doesn't have that thirst sensation. So I wasn't making sure she was keeping herself hydrated. What happens when they have syncope? They fall, right? And then they can come back in. With this, bowel integrity can lead to future problems with organ dysfunction. Delirium may lead to altered appetite. I've actually had patients tell me they didn't eat in the hospital because they were afraid the food was poison because they were still a little delirious, right? And also, again, that altered microbiome. So we need to keep all this in mind. And also, the last one, that if they still don't eat for months or for weeks, we need to have educated that family to say, hey, if they're not getting any better, you need to talk to somebody about maybe artificial nutrition, with getting feeding access in your loved one. So we need to think about what we're doing for these patients throughout the continuum of care, because there's all these interrelations and everything kind of cross-references. So it's everybody's job. It doesn't matter where you work as a dietitian. PICS is going to affect your clients wherever they are, and they're always at risk of getting malnutrition. And this, what Dr. Miller introduced earlier, kind of shows us that. I mean, just for a second, look at the targets on this graph. So that by post-hospital discharge, they may be up to 150% of predicted need. So are we hitting those targets? Do you know if your patients are getting those targets? Well, in a minute, I'll show you what I found out about my own patient. But first, this was a study done in Australia by Dr. Ridley. And they wanted to know, when their patients left the ICU, how did they do on the ward? Were they eating? Were they not eating? So what they did is they kind of looked at, were they meeting their combination of nutrition, of protein and calories? And I'll just look at the bottom on the protein one, because we know that's probably one of the most important for recovery. And when they were looking at oral nutrition only, so those that have been provided a tray and they don't like the oral supplement they get put on, those are the patients that are only getting 48% of what's prescribed or what's predicted that they need, 48%. And yet, when we leave, do we think they'll really go up to 150%? Probably not. So this is what I'm starting to look at in another study I'm working on. I'm looking at these patients that have had COVID and then went on home, but we're actually looking at every COVID patient that enters the hospital. And I'm like a crazy person, and I'm looking at how much nutrition they got through their entire stay, from the ICU to the ward, and then went out the door. And if I put all that together, and I'm using just enteral and parenteral here, because I know then exactly how much calories and protein were delivered, right? Because I can calculate it. But if I put it all together from what was prescribed to deliver, most patients are getting less than 25%. So it's tough. It's tough to meet these goals, but that's what we need to start looking at. So what do we need to do now for our at-risk patients? Well, I mean, just kind of go over these main headings, and then underneath all of them, I've got some of my ideas, but I know all of you out there have a lot of other options and ideas that you can share with your colleagues to maybe get things going. But first, we need to recognize who's going to have a problem, and we need to get on it from the get-go, not wait till time of discharge. You got to think outside the box. If they're not hungry at mealtime, maybe they'll be hungry at 2 o'clock, and we should have a cold supplement ready to go, or a snack. Maybe they need a feeding tube. We need to talk about that. We need to check in with our colleagues, right? What's happening in PT? Do they seem like they're getting stronger? Are they getting weaker? My RN, are they sleeping through meals? Is that why they're not eating? And we need to listen to the patients and the family. We can't just order a supplement and have them put it on the tray. We need to say, do you like it? Does that work? Can you get it when you get home? Is it going to be too expensive? You need to think about if you can't eat after a couple weeks when you get home. Do you want a feeding tube? Yes or no? So we need to educate and validate their feelings and let them know what their options are. And we need to communicate with each other along the way. And that, I know, is one of the hardest things, is to say, hey, this is what happened. Now let me communicate to the rehab dietitian that's going to be picking up my patient. And now, if you didn't get enough and you just want to learn more and more about this topic, I'll suggest that maybe you check out this great webinar that was hosted by ASPEN, where 3 dietitians spoke just on the topic I covered here in 20 minutes. So you'll get a much more in-depth view than I could offer you at this time. And then with that, I am going to say, Keith, take it away.
All right. Okay. Well, thank you all very much. So I'm accompanied by the esteemed Dr. Taylor and Dr. Rosenthal that you just heard from. I tried to wear the same thing that I wore the other day. I only have one set of good clothes. But we got a bunch of questions here. We got 40 questions, and there were no bad questions this time, which is also an anomaly. I'm going to try to group them up in a way that we can hit our experts here relatively quickly. We only have about 9 minutes for questions. So let's start off with a question about, let's hit probiotics first. We got a lot of questions on probiotics for you all. And let's start with an easy one. This could be a one-word answer. Who should we not give probiotics to?
I would say, there's a black box warning for liquid transplants. So bone marrow transplants probably would be the population. The Propecia study in pancreatitis might be another one where I would be cautious giving probiotics in pancreatitis, but there were several other randomized control trials that came out after that study that supported use of eco-immunonutrition. So pancreatitis might be one of those ones where if you are able to feed the patient, they're doing okay, they're outside the throes of the acute insult, they might still be able to get probiotics.
In transplant patients is the only place that we're holding off on them right now, whatever the organ is, but we just hold off on transplant patients.
Okay, and I think a common question here for you both was, which or what probiotic do they give? What do they take back to their home institution and say, this is what we're going to give in our ICU?
Yeah, I would say that's always a question that we get when we talk about probiotics. The probiotic literature right now does a really poor job on telling us which bacteria are the best to give. There's Reuteri, rhamnosus, there's a lot of Bifidobacterium, lactobacillus. There's I think the consensus and the biggest take-home message for probiotics is to increase the biodiversity. Don't get married to any one product. Try and change it up. We have, fortified yogurts. We have kombucha. We have pills, enteric-coated pills. We have a lot of different things that could provide probiotics and fortify the biodiversity. And the other thing is you want to pay close attention to trying to get supplements that have really high colony-forming units, like in the billions of colony-forming units is probably where the 2 biggest signals are. So biodiversity and high colony-forming units.
Yeah, and I agree. I mean, we're stuck also. This is why I said we have to kind of get our pharmacy folks embedded in this conversation because it changes. Whatever's on formulary at the time might be the probiotic capsule that we have available. We have the probiotic enriched yogurt that we can give the patients when they start to eat. I'm interested in some of the places, I know Dr. Martindale does, is using kefir in the feeding tubes and looking at a potential protocol to get that started. So I totally agree with everything that Martin said. It's just, I wouldn't get hung up on a brand name or something like that. I would just say, give what you can give and what you have available and, change it up.
Yeah, so people came here wanting to hear about PICS, and here we are talking about probiotics.
But it's good. I think you have to, in these PICS patients, right? We've just wiped out their microbiome. So that's the point, is during their recovery, And so when you're talking to them as a dietitian, you're getting ready to discharge them to the rehab or wherever they're going. You can say, hey, try to, use a lot of different things, eat some yogurt, do these things, to get that reestablished. So I think that's why it's really important.
Yeah, and relevant to this. And so but I guess how long do they stay on those things? You got a recommendation for that?
I had a kefir shake this morning.
Yeah, I take them daily. The only times I don't take them is when I forget them when I travel. And I would say that, fortifying your GI tract and understanding what the microbiome and health can do for us only will help us elucidate what the microbiome does to us in stress and in a pathologic state. So I don't think it's going to hurt. And, we know very quickly that the microbiome shifts and gets augmented rapidly. We're talking like hours to days. And, when you're a polytrauma patient, when you're pancreatitis, when you're fighting for your life in the ICU, your microbiome is shifting right then and there. And when you start taking probiotics, it too will shift very quickly. And Alverdi shows that with some of his fecal transplant papers that he did with a mouse model.
Good. So so we only had 2 minutes for probiotics. So hopefully we got most of those questions answered. Let's move on to some of the components or constituents of immunonutrition. A lot of questions about arginine, omega-3 fatty acids. So some questions about which population, when to start it, is there anybody you wouldn't start it in, and how long do you keep it going?
So coming from a surgical trauma intensive care unit, pretty much almost a lot of my patients, majority of them would get an immunonutrition product for at least 7 to 10 days. And then I would switch them to another standard product with high protein at that point, because our data doesn't tell us much beyond that 7 to 10 days. In the medical ICU, the data is not as clear. We didn't see the benefit in the data. That's why in the guidelines, we didn't recommend it necessarily in the MICU patients. I think more because a lot of those patients are these chronic critically ill. But if you have a patient in there that's had a recent insult or something, you might consider it in the MICU as well. But I definitely use it in the surgery and trauma patients.
Yeah. I don't want to touch on the entire controversy surrounding some of the amino acids and sepsis and shunting down nitric oxide pathway and stuff. There's a great pilot study that Yvette Luking did out of Texas, and she gave super physiologic doses of arginine to septic shock patients and showed that the MAPS didn't change, the blood pressure didn't change. And so I think, though there is a controversy, I just wanted to remind everybody that we're talking about PICS, and we're talking about patients that have already had source control. They are through their septic insult, and now we're trying to fortify through nutritional supplements, their immune system, their wound healing abilities, and give them back things that they're lacking, because arginine is typically a conditional amino acid. And, the branched chain amino acids like leucine really are nice to hopefully promote anabolism. And, the body of omega-3 fatty acids in the SPM story is, it's shaking the entire nutritional community, because we're starting to understand that, inflammation resolution is a completely active process. And if we can give these molecules to patients, they might have a clinical benefit.
And I think Martin brings up a really important point. It's thinking about what can I do as they're in that recovery acute phase in my ICU that will help them as they recover on the ward, and when they go to rehab, and when they're home, what steps can I take there? And we haven't done the data yet. It may be that even for a longer period of time, if they still need enteral nutrition, or there's oral supplements that have these available. And when you're talking about in the product, you're not giving mega doses. So you're given a safe amount for these patients. You don't have to think, oh my gosh, am I going to give them too much arginine, this controversy. This is to replete that they're probably depleted some. So I would not worry about that.
All right. What about anabolic steroids? Several questions about that. Yes, no, in the ICU for patients at risk for chronic critical illness?
So,
I think, go ahead. No,
I would say no, I would not do it in the ICU, not anywhere near any kind of sepsis events at that time. But when they're beyond that recovery phase, and maybe even when they're to the ward or so, that would be the time to consider the anabolic hormones. Probably for men, it's easy to check a testosterone level, see what that is if you want to give testosterone. The data is there's not a lot of data except in burn patients. And Martin, I don't know if you know of any in PICS where it's been helpful. So
no, it seems like I think David Hernan's pretty much countered that entire market, if you will, because I mean he studies a lot of pediatric burn patient populations, looks at anabolic supplementation, trying to decrease cardiac oxygen consumption to, kind of augment the cardiometabolic response to big insults. And, oxandrolone, a lot of these steroids are beneficial. They increase bone mineral density, preserve lean muscle mass. And so we do see that, but is pediatric patient population, whether or not that transitions to the adult population, I think is kind of yet to be published. But I do think it can be helpful. I mean, sometimes you don't need a study because you have such theoretical benefit that you can just give it, but you just don't want to cause immunosuppression further with your steroid selection.
Right. So you just would have to be cautious. And like you pointed out, and those practitioners that are listening that are taking care of pediatric patients, that would be a discussion to have with your medical team. And when would you start it?
So I think that wraps it up. We've got a couple minutes. They gave us a 5-minute cushion if you want to use it. What do you think?
To you, man.
Got another question?
All right,
well, take another question.
Yeah, let's take this one. So we talked about a lot of these adjunctive therapies, and we've talked a lot about using them in the ICU, but at least in Louisville, Kentucky, I don't know that we're still going to be around 3 to 6 months after the patient leaves the hospital. And if we are around, it's for very specific reasons, not necessarily for the big global continuance of care. Who takes charge of these patients? What does that multidisciplinary team look like? It's probably not going to be the in-hospital dietitians and the inpatient sort of service providers. Who's going to take charge of these patients, and where does this education need to go?
So I think that's a great question, and I spoke to a little bit, but as we're looking at these PICS patients in our clinic that we're looking at, we're finding out that really nobody. This is one of those gaps in healthcare across that continuum. So we may communicate with the ward dietitian as a dietitian, and they may pass it on to rehab, but not always is there great communication with physicians. As we go into the electronic health record, you may get some more communication, but really it falls on their primary care providers. And so I think one of the things that we can do is in the inpatient setting is when we're doing our education for these patients and families, we need to educate them for 3 months, 6 months down the road. And so that they understand even questions they would need to ask their primary care provider. Or if you're having these problems, you ask them to say, hey, I think I need to see an outpatient physical therapist or a dietitian or, whatever. So sometimes it might, and then we need to also try to educate primary care providers to give them some information because they don't always understand what happened in the ICU, right? That's not where their focus is. And these are leftover complications from that ICU stay.
And I said it better.
Yeah, very good. Well, they're going to shut us down. Martin, Beth, and I are going to sit here and talk about PICS for another couple hours, but I think our programming's done for the day. So I certainly appreciate. Thank you to Nestle. Thank you to all of you for joining with us, and I hope you have a great rest of the ASPEN meeting. So thank you very much.